Hello, good morning, good evening, everybody, depending on when you are around the world. Thank you for joining us for this new IATH Junior Club that is part of the activity of the IATH. Today, we'll have a very interesting clinical case presentations by Professor Mateo Mejia that is working in Cornell Medicine in the United States. He is going to show us that not all paraproteinemia is myeloma. As an invited expert, we have Professor Uriel Suarez that is working in Madrid. So now I will invite Professor Mejia to present his clinical case. Don't forget that you can send all your questions through the chat, and we'll take the question and have some very nice discussions at the end of the presentation. So please, you can start.
Thank you so much, Professor Millard, and thank you for the IACH for inviting me. It is really a pleasure for me to be here. I'm going to walk you through this case, which happened about 2 years, and not only the clinical data, but I'll try to give you the idea of how everything happened in real life, so we can do a little bit of what we call an autopsy, a dissection of the case, all the risk of the clinical reasoning that can happen in these cases. And again, I'm very excited to be here. I love the IACH seminars, and it is a pleasure to discuss this case, which I think is very, very relevant and interesting. So let's start. This is Mr. A. He's 70-year-old male. Everything really started back in February 2021. And when he started feeling some constitutional symptoms, some fatigue, weight loss of about 9 kilos in the span of about 3 months, he was actually admitted in Florida, where he was spending some time over the weekend. They noticed, we don't have really all the records, but apparently it was for this generalized fatigue. They noticed some thrombocytopenia, so elevated white count. They did this like general assessment. We don't really have a lot of the records, but he was really discharged home, and he returned to New York City when he presented to our hospital here at Weill Cornell. At the time we saw him, it was April 2021. The symptoms just continued to get worse. He was very, very tired. He was having a lot of issues to the point that he was really requiring a lot of assistance even for walking. And just to give you an idea, this patient was playing golf 3 or 4 times a week, was very active, was completely independent. As you can see here, although he had some history of cardiovascular disease with coronary artery disease, hypertension. As I said, this guy is 6 months before the onset of symptom was completely asymptomatic. He doesn't really have any other toxic history. And then when he was seeing as an outpatient here in April 2021, he was so deconditioned that after the first set of labs that I'm going to show in a second, he was actually admitted on the following day just to expedite the diagnosis, because there was a clear decline in his functional status. When we saw him, his physical exam, you can see he was tachycardic. He looked very chronically ill appearing. He wasn't even really able to stand up from the chair by himself. And the physical exam was very prominent for some diffuse lymphadenopathy in the cervical region, axillary region. All of them measure about 1.5 centimeter, except one in his right groin and his right inguinal area that was more prominent, measured about 3 centimeters. They were non-tender. There were shorter lymphadenopathy, and he also have a palpable spleen tip 1 to 2 centimeters below the costal margin. He did not have, I forgot to include here, he had a erythematous rash in the thorax. It was very faint by the time we saw him. Patients said it tend to get appear and disappear for the last week or so. And these are the labs we did in that first day in the clinic. So as you can see, there's a very significant leukocytosis. There's some anemia, which, by the way, was normocytic, and some thrombocytopenia with some additional workup that we did. He had an acute kidney injury. His baseline creatinine was around 1.1, so this is definitely new. His LDH was also elevated. And I think what is very remarkable is he was very hypoalbuminemic. His albumin was 2, with a total protein of 12.5. And when we review his peripheral smear, this is what you can see here. He had most of this leukocytosis was really at expense of this cells, plasmacytoid cells, eccentric nuclei. You can see the perinuclear half, open chromatin that were consistent with plasma cells for the cytotechnologist. So of course, I mean, the patient was already admitted by the time we got the full report and all alarms went off. He was initially actually admitted to the leukemia services because the concern was that we were dealing with an acute myeloid or lymphoid process. A PET scan was expected. It was actually obtained that same day. And this is a little bit of the images that you can see. The report was significant for many FDG avid lymph nodes, as you can see here. I mean, we have some axillary, we have some mediastinal lymph nodes, para-aortic, there's some of the inguinal lymph nodes, and the cervical lymph nodes that we also saw on the physical exam. The max SUV for this lymph nodes was about 18, and all of them were very consistently around that value. There was also very clear splenomegaly that was diffusely FDG positive. Again, going back to the physical exam, that's what we saw. And I think we're very lucky. We can get a SPEP and serum free light chains in a very fast time. And within a day, we got all these results. So you can see here, this is his total immunoglobulins. You can see, and the reference is, I placed the upper limit of normality for our lab. So you can see there's very significant increase in pretty much all the immunoglobulin isotypes. Also in the serum free light chains, both elevation of kappa and lambda. And in the SPEP, they actually notice 3 clonal peaks, one of them as high as 3.1 grams per deciliter. And the serum immunofixation really showed a biclonal IgG lambda with some monoclonal free lambda light chain component. So after these results, the lymphoma service actually said, well, you know, with this peripheral plasmacytosis, with this SPEPs and this paraproteinemia, I think this is primary plasma cell leukemia. I think we should be transfer the patient for myeloma and start therapy as soon as possible because, as I said, the patient is discompensated quite quickly. I want to make a stop here because I think there's a lot of momentum. And as you can see, things are happening very fast. And I think what is very important about this case is not only the final diagnosis, but also all this clinical reasoning that happened in the meantime, right? I think I want to just put a comment or question out there. Do we have a diagnosis? Is this plasmacytosis, as I said, is more than 30% plasma cells in peripheral circulation with many, over 1,000 of plasma cells? Is this enough to call this plasma cell leukemia? Are the rest of the tests that we discussed, the paraproteinemias, the PET scans, compatible with this diagnosis? And I think I want you to kind of ask yourself if there's anything that doesn't fit in this case. And I put it here, are we at risk of any bias? And I think we are. We need to acknowledge that this is happening very quick. I think one of the bias that can happen is momentum bias. So when people are concerned and they're moving really fast, there's risk of just keep doing what we're doing, right? And having that, with that unchecked, I think it is important to acknowledge that can happen. The other thing is there's anchoring bias. Do we think this is plasma cell leukemia? We're going to keep thinking this is plasma cell leukemia. So with that in mind, luckily this patient had very accessible cells that we can check. And one of the first thing we did was, of course, that same day that we got all the results, we did a peripheral blood and bone marrow, right? And we rushed the specimen. Our pathology team is great, and they work with us. And within a day, we're able to get the results of the flow cytometry in peripheral blood, which is what you see here. So what you're seeing here is basically the lambda and kappa, so the cytoplasmatic lambda and kappa for this peripheral blood. And as you can see here, there's really no kappa or lambda restriction. And I want to remind you that the peripheral, the SIFI show there's IgG lambda and free lambda, right? So to begin with, this peripheral plasma cells were not lambda restricted. You had about a 50% of lambda and kappa. If anything, they were more kappa. By the way, this was exactly the same that was seen in the bone marrow. And then when we review the bone marrow, even in the aspirate, they tell us, oh, there's more than 50% of plasma cells. You can see here the CD138 that stands for plasma cells. You have an overwhelming positivity for plasma cells. So most of your cells in the bone marrow are, again, plasma cells. But when we did the kappa and lambda restriction, both by flow and immunohistochemistry, you can see that there's no clear specific restriction. An NGS panel and a PCR for the IGH and IGL locus was sent, but this will take some time. And then I just want to highlight that CD20 what didn't really show much. And here you can see the bone marrow biopsy, the core. You can see that there's overwhelming of this plasma cells that are again eccentric nuclei with a perinuclear half, and it's comprising more than 40% of the cells. So I just want to take a step back, and this is kind of what we did. Okay, is this compatible with plasma cell leukemia or with multiple myeloma? And going back to the prior slide where we were questioning the diagnosis. So I think, and I think classifications are so important because they help us classify patients. But I think we often just rely on the numbers and we blindly go with this. And this is a lot what we discussed with the residents and the fellows that were involved in this case. So when we think about the active myeloma and the new, well, I say new, but it's over almost 10 years old, the classification for multiple myeloma, we always are fixed on this more than 10% plasma cells in the bone marrow, but we forget the very important clarification that has to be clonal plasma cells, right? Because multiple myeloma is a clonal process in association with slim crab, and you can see here all the criteria, which this patient, by the way, if we blindly go by that, he has anemia, he has acute renal insufficiency, he will meet the criteria. And I want to remind that recently we have changed the bar or the definition for primary plasma cell leukemia. We used to be much more strict. We used to have more than 20% and more than 2,000 plasma cells in peripheral blood. But since the outcomes of the patient with more than 5% are similar, we're really much more inclusive, and primary plasma cell leukemias or plasma cell leukemias really consider anybody who has more than 5% of plasma cells. But again, we need to show that they're clonal. So with this in mind, we said there's something that doesn't fit, right? And if we go back to his clinical presentation, I mean, could you have primary plasma cell leukemia without lytic lesions and with all this lymphadenopathy? Extramedullary disease is a possibility, right? So it can happen, right? The other thing that doesn't fit is a lot of the rash. That's the other part that we were kind of saying, this might not be the typical presentation. So because this is not really fitting well, we did something else. So we went for one of the lymph nodes that was very, very FDG avid in the cervical area. We did an excisional biopsy. And this is a little bit of the report. I hope the magnification is not too low, but this is the low power. You can see that this lymph node, there's really barely any follicle structure that you can recognize, so it's very effaced by a proliferation of atypical cells that are small, right? Which is important if we're thinking about the classification between large or small lymphomas, right? They actually saw a bunch of plasma cells as well, at least very abundant. As you can see here in the 138 stain, there's were also plasma cells, but they also saw prominent vascularity with high proliferative of endothelial granules. And when we did the immunohistochemistry, so you can see here that most of the cells in this structure were CD3 positive. So that's where we're starting to think about a T cell process. And if you see the other markers, they were CD4 positive, they were PD-1 positive, they were ICOS positive, and I want to highlight that many of these CD138 cells, again, when we did the kappa and lambda immunohistochemistry, there was no clear restriction. So we're seeing again what we saw in the peripheral blood, in the bone marrow, that there's no clear kappa or lambda restriction. So with these findings, we went back to the bone marrow and we said, like, we have this population of T cells, abnormal T cells expressing this ICOS PD-1, and by the way, it's not included, but there was loss of CD7 and they were actually positive for CXCL13. We went back to the bone marrow, and I hope this is clear. There was actually some involvement by in a much smaller proportion by CD3 cells. This is the biggest aggregated pathologists could really find. In many other places it was much more scant, but you can see that the immunophenotype is similar in this case. The CD3 positive, CD4 positive, PD-1 positive, CXCL13 in this case was called indeterminate. But what is interesting, when we did a TCR-PCR to really assess for clonality, there was a clonal peak that was very marked in the lymph node, and it coincided with the exact same peak when we repeated retrospectively in the bone marrow. So With this, we arrived to a diagnosis of angioimmunoblastic T-cell lymphoma with bone marrow involvement. And I think, I mean, retrospectively, I think that we were able to show that there was bone marrow involvement. I think initially pathology, or this whole picture, was a little bit confused by the abundant plasma cell infiltration. But with this, we arrived to this diagnosis of AITL. So just to give you a little bit of a background, I love history in medicine, and I think AITL history is amazing because I think there's few diseases that have had so many different names over the time, and this is because AITL is a lymphoma of many phases, and we can start here where we in the 70s, because you have all this prominent cellular features with plasma cells with vascular proliferation that we were not even sure if there was even a malignant process, right? So you have all the angioimmunoblastic lymphadenopathy, immunoblastic disease, right? When we realized this is a T-cell process, a T-cell driven process, it was thanks to really the identification of the T-cell origin, and also the identification of some of the features of a T follicular helper cell, which are the markers that I mentioned before. So ICOS, CXCL13, PD1. And I think more recently, from 2015 and onward, AITL has been, I think, the poster child of how genomics can help us identify a single disease presenting with different phenotypes, right? So identification of gene expression profile and RNA sequencing has helped us to identify that AITL, or what was known as AITL, is just one of the ways of follicular helper T-cell lymphomas of presenting. And in addition, we identified all these mutations. But by the way, I forgot to mention, it was present in our patient. He had a TEP2 mutation at a typical site for AITL. So just going back to our clinical presentation, I think this patient, and now looking at better, if we forget the plasmacytosis, I think the diagnosis would have been extremely straightforward, or not extremely, but I think the plasmacytosis was really making everything a little bit more confused. He had lymphadenopathy, he had hepatosplenomegaly, he did not have warm hemolytic autoimmune anemia, and he did have hypergammaglobulinemia and constitutional symptoms. And this is just a description of the many ways AITL can present, and you can see here that it can even present with hypereosinophilia, hypergammaglobulinemia, thrombocytopenia. So with that in mind, we had a question. So what's all about with this plasma cells? And many of us were saying, well, yes, there is a reactive plasmacytosis, but what is driving this? And more importantly, how come the SPEP, or the serum protein electrophoresis and the serum immunofixation show a clonal bands? Remember, there were 3 bands. I think there's very important points. So first of all, plasma cells can have proliferation under reactive circumstances, and this is usually driven by cytokines. And as you can see here, all the secondary process that can be associated with that. And there were clues to begin with. There was no reciprocal depression of any of the other immunoglobulins. Both kappa and lambda were elevated, right? So, and I think those are clues that are telling us that this was a reactive process. And just to give you an idea of what happened with Mr. A, so he received BV-CHP mini. It was actually dose abbreviated or dose reduced because he was in very compromised shape. He achieved a complete response, but rapidly he had progression of disease. He received some romidepsin at that point, with somewhat of a response that lasted for a couple of months, but then he relapsed again. And then he received bendamustine roughly 6 months after diagnosis, and he achieved a complete response that it's still ongoing to date. So he's been on CR for almost 2 years and change. He actually had a PET scan last week and is still in CR. So he's feeling great. He's going back to playing golf. His quality of life has improved significantly. And just to show you, his IgG, every time that he relapsed coincided with increasing his IgG and his M protein. And since he is in CR, this has since resolved. And that is all I have for you guys for the presentation. Happy to go over any questions, any discussions you guys have.
So Thank you, Dr. Mejia. It was really a nice presentation on this kind of always difficult to diagnose AITL, because this is a very very nice presentation when we think acute leukemia after myeloma, and after we at the end it was a lymphoma patients, and it's really give a comprehensive presentations, and also the data regarding the treatment are really interesting, because I am impressed by the 2-year complete response with the bendamustine you achieved. So we can take some question now through the chat. We'll start with the first question from Dr. Irimia, that asks if you have some experience with reactive plasmacytosis in the context of cytokine release syndromes. For example, she see a patient that have an Hodgkin lymphoma that has this reactive of 30% of bone marrow plasmacytosis at the onset of cytokine release syndromes. Did you have some information regarding that, if this has been reported?
Yeah, I'm not sure if it has been reported. I mean, Hodgkin lymphoma itself is a cause of secondary plasmacytosis, and I think AITL and Hodgkin share a feature that a lot of the symptoms are tumors that are very. It's not like when you see DLBCL that you see sheets and sheets of malignant cells. A lot of what you're seeing is the interaction of the neoplastic compartment with the microenvironment, and I think that's where a lot of the B symptoms in Hodgkin lymphoma comes from, right? It's not really being secreted by the red Sternberg cells, it's actually the interaction with the microenvironment leading to cytokine proliferation, right? And I think that's similar to what we're seeing in AITL. We actually measure IL-6 in this patient, was elevated, and every time he responded, it went down. So I think in all the disease that share this close relationship with the microenvironment, you could see this specifically. And, you know, I'm not sure if with cytokine release syndrome specifically, but we have seen, I mean, IL-6 is a strong pro-survival signal for plasma cells, right?
Yeah. Good. So now, so you can send all your questions to the chat, and I will go to Professor Suarez. So first question is, what do you think about this clinical case? What is your feeling? And after, I think you have several questions to ask Dr. Mejia. So now the floor is yours.
Hello, everyone. Thanks to Professor Mallar for sharing this academic space with us today. And thank you for Mateo for accepting the invitation and for this nice and instructive clinical case. I have some questions which I hope we can solve together. First, do you know other causes of non-hematological monoclonal gammopathy?
Yeah, I think that's a great question, and I think it is more common than what we recognize, and I think we see it much more often. It's just it's not to this extent, right? So how many patients? I think a very frequent referral we get is elevated IgG, IgM, and IgA in the setting of autoimmune disease, right? So I think SLE, for example, lupus or autoimmune disease are very common. Also, infectious processes with chronic immune stimulation, such as Hep C, hepatitis B, HIV, are commonly associated with hypergammaglobulinemia, right? It's just, and actually, by the way, I think from chronic stimulation, you can have what it looks like monoclonal peaks on the serum immunofixation, that often when you do mass fixation or more sensitive methods, they might actually not truly be clonal, right? I think to the extent of this case is much less common. I think some other infections have been associated with severe plasmacytosis, but I think hypergammaglobulinemia is very common, and I think that's why I love myeloma. I think myeloma is more than a set of criteria. It's really the clinical setting is paramount to really make an interpretation of what you're seeing in the protein electrophoresis.
Very good, great examples. My next question: what are other markers can help us recognize monoclonality apart from light chain restriction?
Yes, I think that's a great question. I think to just remind everybody that light chain restriction is a surrogate for monoclonality, right? Because if you're a plasma cell that is developing, is flipping a coin, let's say if you should be 50-50, right? But in the end, you're not really proving monoclonality. So light chain restriction is useful. I think what I mentioned is the clinical setting is very important. And I think there's some other subtle clues. For example, when we have a plasma cell a process or monoclonal process that is involved with the bone marrow, immunoparesis or reciprocal what we call reciprocal changes in the other immunoglobulins, it's very suggestive of that, as opposed to this case where all immunoglobulins were elevated. So if you have an IgG myeloma, let's say, with a 2 grams of IgG kappa, I will expect total IgG to be elevated, and for example, IgM and IgA to be decreased, right? And I think many have shown that that is also prognostic as well. For example, in the precursor space, especially the Spanish group has worked and has shown this was incorporated in their PDMA model for risk stratification for MGUS and smoldering myeloma in the past.
So I will just, while we are speaking about the light chain, jump in because we have a question from Dr. Radwan that asks for clarification, because as you show, there is some kind of discrepancy because the serum-free light chains results, because you show that there is the same level by the flow cytometry between the kappa and the lambda, so it indicates it was not clonal. But on the other hand, you find that with the IgG, it was a kappa-like chain, I think, and we did not find an excess of this light chain. So do you have an explanation regarding this kind of discrepancy?
So I think that the big discrepancy is between the serum immunofixation results and the, let's say, the rest of the test, right? I think one of the things that we need to acknowledge is the serum immunofixation is a great method. And I think it's, I mean, it gives us so much information, but these cases where you have so many immunoglobulins, right? And in the end, this is a gel that somebody needs to read, right? When you have so much noise and when you have so much polyclonal processes, right? You can start having on a specific binding and you can start having on a specific bands, right? And in the end, the cytotechnologists, when they're reading, or the pathologists, when they're reading these gels, there can be some bands that are hard to recognize, either because there's in a specific binding or because there's so much noise in the background that they might give you these reads, right? So I think this is, again, if a test is telling you something, but it doesn't fit the rest of the information, the clinical context, that's where an alarm should go off, and then just start to maybe reconsider this.
Yeah, yeah, you are a very good point that we have to be always cautious with the immunofixation when we have a strong background. I remember patients that come to the hospital to say, yes, I have some monoclonal gammopathy of unknown significance because they find this with the lab. And in fact, it was a polyclonal when I tested in the hospital, and the immunofixation was negative in the hospital, because sometimes also this is some biologists that have not the expertise to do this kind of test. And this is positive. And at the end, when we look closely with all the clinical situations, the test is at the end negative. And it is important because the patient say, yeah, I have this disease, maybe I will have a myeloma one day. She was very worried, and at the end, no, she was fine, and she don't need to come to see me anymore. So it was some good news for her. So yes, still keep that in mind. So I think you have some last other question, Dr. Professor Suarez.
Yes. We continue with the questions. Mateo, do you know if the classification of PTCLs has been modified specifically for AITL, considering the two panels, ICC and WHO 5th edition?
Yes, and I think, as I mentioned before, I think it is an amazing example how genomics have shown us, or have unified our understanding of a disease, right? Because we realized, so I believe before, AITL required a lot of histological features, and then you have the T follicular helper lymphomas that were just kind of lumping between the PTCL and OS, right? And other subtype of follicular T-cell lymphomas, and they were seen almost as like 3 different entities, right? But when we did the gene expression analysis and we noticed that there was a lot of very similarities in the genomic standpoint, I think all those 3 entities were lumping within the same category. And I believe at this point, this is really seen or considered the same entity, right? With maybe different phenotypes. So I'm not a pathologist, and T-cell lymphomas are one of the most complicated ones, right? So I think that's why working with your pathologist is so extremely helpful to really try to get to the bottom, right? And I think this is even more important when you have, when you have such a florid different clinical presentation.
Perfect. Other question now of physiopathology. What is the mechanism of extreme plasmocytosis in AITL or follicular helper T lymphomas?
I think that's a great question, and I think it's the IL-6 driven or cytokine driven. I'm not sure if that has been specifically been proven. That will be my guess. I think there's clear interaction that is driven by the tumor, right? Because in this case, for example, every time that we control the T-cell lymphoma, the plasmacytosis went away. But I think it highlights the importance of understanding the tumor microenvironment relationship in diseases, for example, like Hodgkin and AITL, as we spoke.
Okay, perfect. What is your opinion of brentuximab vedotin first line, the scenario angioimmunoblastic lymphoma?
Yeah, no, I think that's a great question. And again, I treat plasma cell dyscrasias, right? So that's my caveat. But I think it is tricky. It is tricky because Echelon-2, the big trial that compare CHOP versus BVCHP, first of all, it only included patients with a CD30 cutoff of more than 10%, right? And so not all AITLs will be included. And actually, I think CD30 expression in AITL is in the 40% range. And when we look at the number of patients in that trial, AITL comprised like 50 patients. It was, if I'm not wrong, like 15 or 16% of the patients. So you're really doing a subgroup analysis. Echelon-2, I think overall was positive. However, the one of these histologies that did not benefit, at least numerically, from BVCHP was actually AITL, right? So I think that's maybe the background of a lot of the data we have. That being said, in this patient, for example, I know they were concerned about maybe toxicity. I think there still could be use and there has a role. It's just, I think with T-cell lymphomas, getting the data is a little bit tricky, right? And I mean, CHP with BV by itself, let's forget that it doesn't mean it's not less toxic by itself. It needs growth support. It can lead to neuropathy, right? So I think maybe it's another option. I'm not sure if it's first line. I don't know what you guys think. I'm curious to know your thinking about this. And in this case, for example, it helped to cool off everything. Yeah.
I agree. Echelon-2 study includes only small cohorts of CD30 plus, CD30 positive. Is an option. And what is the treatment approach for the relapse or progressive AITL?
Yeah, I think that's also an evolving area. I think and interestingly, I mean, I think if we go back to the genomics of AITL, is very interesting because you have a lot of TET2 mutation, DNMT3A, IDH2, which, if you remember, those are a lot of what has been seen in myeloid neoplasms, right? So, for example, here in Cornell, we have a phase 2, I think it was recently published, with hypomethylating agents in combination with CHOP, for example, right? So I think you have a lot of your very T-cell directed agents. Romidepsin is a good option. Bendamustine, as in this case, I think bendamustine is very, very active and it's usually well tolerated. But I think what is very exciting is to see if we can exploit some of the therapeutic advances in myeloid neoplasms. Can they translate to AITL, for example, right?
So I will jump in because I was waiting for this comment. Do you think that we can test some ASA combined with venetoclax on this kind of treatment could be effective?
Yeah, I think I think it makes a lot of sense, right? And I think it is one of those things that I think with all T-cell lymphomas is so tricky to run trials because it's much less common, right? But it is promising. I think it is a very exciting time for this disease.
And if the patient would have been younger, do you think he should receive allogeneic stem cell transplantation first year, second year?
That's a very good question, right? And I think if we were talking also younger, you might consider maybe CHOP induction, right? I know below 60 years, that's like the other one. I think at least locally, we are, I think most of the time what we will do is probably consolidation with autologous, right? And I think allogeneic, at least we're not so keen, but I mean, to be honest with you, there's not a lot of data, and I think it's fair to discuss it with the patient, right? It is tricky. I think navigating all this very complex and morbid diseases without data is very, very complicated.
Yeah, we don't have any definitive answer. And of course, we always also discuss on if the patient is fit and is willing to do it, we try to go to the allo. But
yeah,
I agree. I think the evidence is scarce, and the best thing is to try to include our patients in clinical trials to answer these questions.
Absolutely. Absolutely. Yeah.
My last question. What is the future of treatment of patients with AITL? A role of target therapies or chemo-free regimens?
Yeah, I think going to what Dr. Mallar was saying, can we have a ASA regimen for AITL, a little bit like myeloid neoplasms, right? And then give us a little bit of chemo-free options, right? I think it's especially for fit patients, it's a hard. I think it might happen a little bit similar to what has happened in myeloid neoplasms, that maybe especially in fit patients where CHOP or CHOP upfront with consolidation with transplant, it's really has been the only way of achieving long-standing remissions. It might be a hard sell point unless we have more data, and maybe in frail patients, but I think it is interesting. I think the other thing is, can we leverage all this immune hyperstimulation that actually causes a lot of the issues initially? Can we in a way steer it to a way of actually being more effective as an anti-neoplastic option, similar to the use of PD-1 ligand inhibitors in Hodgkin lymphoma, which is very active, clearly, right? That would be my thought. I think it's an interesting time for sure for this disease, and I think conceptually and physiopathologically, AITL is so different to many other lymphomas that I think we kind of need to think a little bit outside of the box.
So thank you again, both of you, for these very nice presentations. Do you have a final comment or last comment to do?
No, thank you so much for inviting me. It was an honor. I loved, as I say, all the seminars from the IACH, and very happy to see what you guys have in the future for this junior journal clubs. Yeah.
So thank you again, both of you. Thank you particularly to Dr. Mejia for all the work you did to present this very amazing clinical case. Just I have some question regarding if they can have the record of the video. You can go to the IATH website on all The video are available not the day of the presentation, but next week or the week after. The video will be available online, so you can look at it again and share with your colleagues for this teaching purpose. So this is they are asking that this is because they enjoy your presentations. And also do not hesitate to email me if you have a clinical case you wanted to present us through this platform. So you can propose an interesting clinical case and we'll find an expert to discuss it. So do not hesitate to reach us, and we'll see you again very soon for a new junior club. So thank you again. Have good days and keep safe.
Thank you.
Thank you so much. Have a good day. Bye.